Good morning, everybody, and welcome to the Health and Housing Impact Network. This is the fourth event as part of this first year that we've been running the network. And we are absolutely delighted to have you all joining us this morning. The network has been set up to enable practitioners across health, housing and social care to be able to develop new ways of working together. And it's supported by Impact on Urban Health, which works to reduce urban health inequalities. I'm Hannah Gibbs. I'm the Deputy Chief Executive at Future of London, and I'm the co-convener of the network, along with Catherine Max, who's an independent health and sustainability expert, and you'll hear from her a little bit later. We're also supported by a wonderful steering group and sounding board who help us to shape the programme. So just a short bit of housekeeping before we get started. So we're recording today's session, which hopefully came through pretty clearly when you joined the call, and it's going to go up on our YouTube channel afterwards. Do keep yourself on mute for now. There will be a chance for discussion later and for questions with our panel. But yeah, for now, if you can kind of keep yourselves on mute, that would be great. Also to say, do get involved in the chat function. You can post questions there, which we'll come to later, but it's also great to just say hello, say where you're from, say what your interest is today. And, you know, if you do have any resources you think others would find useful, feel free to use it for that purpose. Sometimes we share those and we do a mail out afterwards as well, so everybody can get access to them. I think that's it for the housekeeping. We're really delighted to have a guest chair today. We've got Shripriya Sudhakar, who is Head of Regeneration at London Borough of Tower Hamlets. She also sits on the steering group for the Health and Housing Impact Network. So she's coming at this from a built environment perspective, but from kind of working with Shri, she has a really wonderful holistic view of placemaking and regeneration and is really committed to making sure that the work that she's doing with local communities and residents is thinking about health as well as the place itself. So she's going to be steering us today and we're super grateful to have her. So over to you, Shri.
Thank you very much, Hannah, and hope everyone can hear me. I had technical glitches, which is why you're delayed with the start. Welcome, and I'm delighted to be here. And as Hannah kindly mentioned, it's a subject very close to my heart, and it's what we also focus on in the work we do in Tower Hamlets. And this event, as Hannah mentioned, is the last of the events in the last year, has been looking at housing and integrated care. And it's a huge benefit for us all who have signed up and registered for this event to work together collectively about housing and health as an integrated system. And every housing issue is also a health issue. And equally, health is fundamental in the way we talk about built environment. And this is, I guess, reflected in the audience today, because I've seen the list of participants ranging from housing, health, and built environment in a very broad sense. That really shows also how we as professionals are also committed. Can you hear? Okay. So I think this morning, the session is going to really focus on housing and integrated care system and the pathways and how we can mainstream housing, health, and care integration both strategically and practically. We're going to listen from professionals who have been trialing, testing, and piloting some of these initiatives. And it's also going to be a great opportunity for us to ask those questions that we all have in the back of our minds about how do we make this work and how do we bring this to London and more broadly to the field. So without ado, just in terms of the setting, the way the sessions will plan out is we have 3 presentations, and that'll be followed by panel discussions and time for question and answer sessions. And we'll all try and keep to the time so we have more time for the questions towards the end. So without much delay, I want to welcome Sarah and David for the first presentation. So they will be, Sarah Roxby is from Wakeford District Housing, and she's Executive Director for Housing there. And David is the Care and Health Manager in the same organization. And what they'll be covering is really looking at how do we break the barriers between housing and health, and what is Wakefield's district housing's mission and values around health and well-being, and the commitment of the integrated care system that has led to health and housing initiatives becoming mainstream, which is the bulk of the presentation is going to cover with some real-life examples. So I welcome Sarah and David to present their work.
Lovely, thank you. Can everybody hear me okay? Got some nods there, thank you. Thanks for the introduction, and thank you everyone for having David and I to your meeting this morning. We're going to share with you some of the work that we've done in Wakefield and also the West Yorkshire region, just to ensure that housing as a wider determinant of health is part of the integrated care system. So if we could just go to the first slide, please. So Dave and I both work for WDH, which is a registered social landlord. We own and manage about 32,000 properties, just slightly over. Predominantly they're based in the Wakefield district, but they're also across West Yorkshire. Just to explain the pictures on the slides for you, for some of you who don't know Wakefield, Wakefield is predominantly an ex-mining community, but we have had over the years some regeneration. We now have the Hepworth Gallery, named after the famous Barbara Hepworth, who was born in Wakefield. And we're also famous for growing rhubarb, if you didn't know that. Next weekend is actually our rhubarb festival. If you're into that sort of thing, I can recommend the gin there. That's quite nice. But as I said, Dave and I, we work for WDH, but we also work for the West Yorkshire Integrated Care Partnership, which is the ICS. We're not employees of the NHS, but we've taken on what we call a devolved model of system leadership, and that's part of the culture across the West Yorkshire ICS. So we just go to the next slide, please. In terms of our business plan at WDH, we have a lot of emphasis on supporting our tenancies, and that's to sustain their tenancy and maintain healthy lives. So we've got a strong drive to develop our health partnerships. The whole organisation recognises the importance of doing this, so capacity is built into our teams to work in partnership, and this approach has been really crucial for Dave and I in terms of taking this work forward with the ICS. Next slide. The West Yorkshire ICS is made up of 5 places. So we've got Leeds, that's the one. We've got Leeds, Calderdale, Kirklees, Bradford and Wakefield. And the partnership actually started in 2016. The ICB, which is the Integrated Care Board, became statutory in July 2022 when the CCGs were disbanded. So the partnership, which is really the wider integrated care system, has worked over the years to build the relationships needed to develop better healthcare locally and across West Yorkshire. The 10 key ambitions are shown on the slide for you, with priorities focusing on reducing health inequalities, managing unwarranted variations in care, and then securing wider benefits of investing in health and care. But there's also a real emphasis on using collective resources wisely by creating an increase in capability and capacity across the system. So that includes the system leadership that I've just mentioned, but collective workforce development is another example. And this includes housing partners, voluntary and community organisations, as well as the statutory health and care partners. West Yorkshire has a budget of 5 billion and we have a population of around 2.4 million people. So next slide, please. To realise the 10 ambitions that were just on the previous slide, we work to embed a culture of improving population health. So this diagram is showing the functions of the Improving Population Health team at the ICS, and this is the team that Dave and I are part of. So housing sits within the wider determinants of health segment, but the work crosses over into a lot of the other areas, so health inequalities, climate change, adversity and trauma and suicide prevention. As a team, we work together to collate data, intelligence and insight, and that informs our actions and plans together. And we consider what we can do at scale across West Yorkshire, across the full footprint, what good practice exists that can be replicated, and where the gaps are that the team need to highlight to influence change across the wider system. On the next slide, I just wanted to share with you what the governance structure looks like. So the Housing for Health programme is overseen by the network, which is shown on the box on the far left. And the programme is led, as I've said, by myself, Dave, and another colleague, Maria. Maria is actually an employee of the ICS, but like I said before, Dave and I are not. So the ICS do pay for our time through WDH, and we give approximately a day a week to this work. To get into this position, we used examples of housing and health collaborations at a place level and demonstrated the impact that collaboration has. So we took a paper to the senior leadership team of the ICS back in 2018 and recommended then that housing and health became an integral part of the system work. And we were successful with that. That proposal was accepted, and this is how we have got into the governance structure that you see before you. So Dave's going to talk to you in a moment about some of the work that has been done, some of the practical work. But before he does, I just wanted to share on our next slide how this then looks like and translates at a place level. So taking Wakefield, for example. I'll talk from the top down, but the structure of this allows for a two-way flow of information. So giving strategic direction from the top of the chart and implementing, but also influencing direction from the bottom of the chart. So you can see there at the very top right corner, that's where the integrated care system, the West Yorkshire partnership sits, and we've got housing as part of that system work. The Wakefield Health and Wellbeing Board reports into there, and I sit on the Health and Wellbeing Board as a strategic lead for housing. And I also sit on the Wakefield Health and Care Partnership that sets the strategic direction and the commissioning priorities. We've circled each of the meetings and the groups for you just to make it easier for you to pick them out. Dave is part of the Transformation and Delivery Collaborative, and he also chairs the Housing and Health Partnership, which implements the strategic direction and reports on progress. But like I said, those groups also help influence change as well. And we also have a seat on the Mental Health Alliance, and that's due to the mental health services that we provide. So I'm going to hand over now to Dave, who's just going to talk through some of the more practical work that we've done.
Thank you, Sarah. Good morning, everyone. I hope you can hear me. As Sarah says, I'm David Thorpe and I'm Care and Health Manager at WDH. It's a really, really great job, and it gives an opportunity really to sustain our tenancies and maintain those tenancies and come from estate management in the housing world from a different guise. On the next slide, please, Hannah. This really starts our housing and health journey, really about tackling health inequalities. So way back when, during the Landsley reforms and the white paper about liberating the NHS back in 2012, we embarked upon a trial with the Primary Care Trust that was then, and it was about addressing health inequalities. So we had health inequality workers that would work with our customers and look at the wider determinants of health. For us, obviously, as the district's largest landlord with 32,000 properties, our best part of, we were seeing a lot of customers who were presenting with health inequalities. So it made good business sense for us to work with those customers. We would deal with the wider determinants in terms of diet, lifestyle, exercise, etc. And then after that initial project, we saw so much benefits that we decided to bring those in-house, and we brand them as on this slide, wellbeing caseworkers now, and we've got 5 of those. But as part of that, we had the work evaluated by Bradford University, and that was an independent evaluation. And the evaluation highlighted across the system that we had a gap in provision of low to moderate mental health services. So we worked up a proposal to have mental health clinicians and mental health navigators, as they're called now, working in our housing team, in our wellbeing team. And those would address the low to moderate mental health issues that our customers were presenting with. For us, you'll all hear that we have the statistic around 1 in 4 having a mental health issue. So if we've got the best part of 30,000 properties, quick maths is we've got potentially 7,500 potential people with mental health issues behind our doors. So by having the mental health navigators and clinicians who can engage with our customers who are experiencing low to moderate mental health issues, it just gives us that perfect opportunity to try and sustain that tenancy and get to the root cause of what is driving or exacerbating those mental health conditions. For example, is it the arrears? Is it the antisocial behaviour? Is it the inability to keep up to the house? We can make sure that that person has the wraparound support from the wellbeing side of things, from the caseworkers, but they're going to get that specialist clinician and that expertise to give the coping mechanisms and strategies. And that's well in bed now within our model at WDH, and that's something that we're really, really proud of. And in terms of the awards and accolades that that model has received, in terms of from the Resolve Award for Approach and Initiative to Antisocial Behaviour, it really does set our tenancies and our model in good stead. On the back of that, on the next slide, please, Anna. Obviously, we have the clinicians from health into housing, and as the relationships grown with commissioners and as things have developed and matured, we've been able to experience and appreciate what some of the problems or challenges are in health. And one of it is all around, one of the problems that they were explaining and experiencing was around hospital discharge. So in partnership and in response to that, we were able then to put a housing professional back into the hospital setting. So we have two now in both the acute trust and the mental health trust. And the idea behind that is just that when a patient is admitted, our housing coordinator will make sure that we're working that patient to profile them as soon as possible, make sure that they've got a housing application form and on a register, and there's no barriers that's going to delay a timely discharge. So when they are medically optimised and fit to be released from hospital, they have got a home to go to, and it's going to be a safe environment that can be sustained. We then had that piece of work evaluated further by Sheffield University, and that highlighted a couple of other issues or potential presentations. So one was around homelessness and also people experiencing living with a learning disability and or autism. So by having this model embedded within the Wakefield system, we'd then be able to replicate and upscale now to West Yorkshire, which is now working at a regional level. So we have now a housing coordinator that is working with those who are experiencing living with learning disability and or autism. So again, really, really well placed, and just showing how the partnerships matured and developed. We had clinicians in the housing space. Obviously, for us, we're sustaining tenancies, and that's and for health, it's preventing people escalating into crisis GP or A&E services. But now on the return side, we've got housing professionals in health space, again, making sure that we've got timely discharges from hospital and people going to a safe home. And then finally, on the next slide, please, Hannah. Following the tragic death of Alabi Shaki in December 2020, and as part of the ongoing commitment to good quality housing across the district, we've entered into a partnership with West Yorkshire ICB to offer support to families, those with young children who may be impacted by damp and mould and condensation, and their homes obviously may be at risk of exacerbating respiratory health issues. So what we have done as part of that partnership, we're looking to deploy smart homes and technology using the Aware tag and the Switchy product, but the fundamentals is addressing the damp, mould and condensation. Obviously, as a landlord, we have all our stocks portfolio profiled, red, amber, green, and risk rated, etc. But we cannot actually give a proactive service by having the people in the team now to deliver support from our Cashwise team. So it's looking at the financial side of things, making sure that they can actually afford the property and to heat it successfully, but also then prevent the underlying causes of damp, mould and condensation, and also advocating on that family's behalf with other support services. And it's all around finding that effective resolution, which could be contributing to detrimental living conditions. So that project's not just for WDH customers, it's across all tenures and offering further support in terms of the wraparound support from our wellbeing services. So again, looking at diet, lifestyle and anything else that they may need support with, whether that be mental health as well. Just to give an update, we've only been going since October last year, but we've made over 600 contacts to customers and identified over £18,000 worth of grants So as we continue with the project, we'll be looking to utilise some of the Internet of Things technology, like I say, the switchy and the aware tag, to help identify and diagnose the cause of damp in advance. And those sensors and monitors will hopefully give us that information that we need, so we can target customers in a timely way, and obviously manage that through the data sets that's coming through to us. So yeah, so just 3 examples there of some of the work that we've got ongoing in Wakefield, something that we are very proud of, and that obviously gives us good traction with West Yorkshire colleagues and partners from a regional perspective. And hopefully myself and Sarah can continue with that shaping and influencing at that regional level with some of the things that we've got in place and embed within Wakefield.
Great. Thank you, David and Sarah. So many things to talk about in our panel, and also about the Rhubarb Festival. That was great to know. So thank you. And wonderful, David, for the examples we'll touch on later on. So now moving on to the second presentation, a pleasure to introduce Dr. Laura Neilson. So Laura leads the Hope Citadel Healthcare, and she also runs Focused Care and the Shared Health Foundation, as well as working in a children's A&E 1 day a week. I don't know how she does it, but one for panel sessions later on. It was all of this work, and specifically the A&E work, I think she really brought to her the link between children's health and the housing conditions, which we'll hear a bit more about. And in the session this morning, she'll be covering about the clinical pathways and her work with homeless families and the challenges of working temporary accommodation and how it impacts on children's health, and her advocacy and the work she's done about getting courts into temporary accommodation, and a real focus on the clinical outcomes starting to drive policy decisions. So great pleasure to welcome Laura. Over to you, Laura.
So it's lovely to be here. Thank you so much for having me. So have we got slides? Yes, good. So yeah, I'm a doctor by training. I do children's A&E on a Monday, and then the rest of the week I cross over primary care and the third sector. So it's quite an interesting combination of things to do every week. I have to say I want to move to West Yorkshire. You guys sound amazing. So I'm from Greater Manchester, mainly based in Oldham. I don't think we have any gin making, but we do make all the cakes for M&S at a cake factory just opposite my practice, which is really good for obesity because they do very, very good cheap Colin the Caterpillar cakes. So just to briefly talk to you about what a clinical pathway is to start with. So I don't pretend that you guys you might already know this, but if we just have the next slide. So it's sometimes helpful to understand how the NHS thinks at a clinical level. So normally a patient will present, so you might go to A&E or GP and you say, I've got this problem. You'll be assessed normally by a clinician. You might have some tests arranged, blood tests, x-rays. At some point you might be referred on to a service. At that point, there can be a bit of a wait at the moment. And then from that, if life is simple, you get the treatment. We see if the treatment works and you get review. So our clinical pathways are built, they're quite fascinating, but a lot of them are built on single diseases, which is interesting. So medicine at the moment needs to understand that most of our patients have lots of diseases in one go. And at the moment, we have lots of single pathways. And the social determinants of health, when I qualified about 15 years ago, was boiled down into 2 questions you asked when you were assessing patients. One was, what's their social history? And you basically want to know who do they live with, but really very, very basic. And secondly, did they take any drugs or alcohol? That was kind of it. So if you think about that, is the background that medicine was working 15 years ago. It's currently undergoing a bit of a transformation, but a lot of the guidance lags behind. So that's just quite interesting for you to know. I became interested in health and housing quite early on. I moved into an area, a lower economic area, when I was 18 as part of a church project. And I'd never lived in a kind of poorer community before, and it was just absolutely mind-blowing. And I lived there till I was 32. And it kind of really changed me as a person. It changed what I understood. I think living in an area is really different from being a professional in an area. You see things very differently. My children had to go to the same GP as everyone else's children. We didn't have a dentist. You saw how the kind of system is really clunky. and there's quite a lot of stigma involved. So that really shaped kind of my clinical practice. And it was from there that we decided to set up a GP practice for the estate that I lived in, because there wasn't one. So at 25 as a medical student, I opened a GP practice, which was a bit bonkers, and that's now grown to 10 practices. The link between health and housing is really clear, and you guys know this a lot. What do you do about it is interesting. One of the specific pieces of work that I've been working on is about homeless families. So if we just look at the next slide. So this is the kind of accommodation that is reasonably typical for families living in temporary accommodation. So often it's hotels, often it's very short, it's meant to be short stay, but it can last for a long time. There's definitely issues of overcrowding, damp, mold, suitability. So 5 years ago, I just noticed from our GP records that we seem to have multiple children living in the same address. And that was when I kind of clocked that this can't all be the same family, even by our standards. So then we realized it must be some kind of temporary accommodation. And that really started me being curious about how many children live in temporary accommodation. We did an FOI, because at that time it wasn't routinely counted nationally. At the moment, there's about 139,000 children living in temporary accommodation. In London, which I know a lot of you are from, it's 1 in 23 children, which is staggering. So a lot of this, is quite common. Temporary accommodation around the country varies quite a lot, let's be honest. So there are pockets of really good temporary accommodation, and then there's kind of mainly in the cities where the kind of system has kind of fallen down. Sorry, an FOI is a freedom of information request. So you can write to organisations and say, under freedom of information, please can you give me this information, and they have 28 days to give it to you. So what's interesting about this is that I am a doctor. I don't know huge amounts about housing. I definitely didn't at that time understand the housing regulations and the rules and all that kind of stuff. So I kind of bumbled into it. But one of the pieces of work we did do was I just asked if there had ever been a child mortality review into children dying in temporary accommodation. Now, I thought it would have been done, but actually it turned out it hadn't. So one of the pieces of work we did last year was to work with the National Child Mortality Database team, who are based at Bristol University, and just ask the question, do we know? And from there, we identified that 34 children had died in temporary accommodation over an 18-month period, which is statistically higher than you would expect. So when we looked at what was going on, it's difficult to say, but we do know that cots and safer sleeping is really important. So that became one of our 5 asks to mitigate the effects of temporary accommodation on children. And this year we launched, if you just do the next slide, this year we launched our cot campaign just before Christmas. If we crack on again, sorry. So we launched our cot campaign. So this was a video that we launched as part of an APPG. Now, an all-party parliamentary group sits at Parliament. It's cross-party. Somebody said to me, what you should do is start an all-party parliamentary group. I had to Google what it was. I had no idea how you do them. I didn't understand how it worked. But anyway, we had a go. And now we have an all-party parliamentary group looking at temporary accommodation for children. And this was one of the campaigns they did. I don't know if this video is going to work. Is it going to work at all? No. So we basically...
I didn't realise there was a video.
That's fine. It probably didn't quite transfer fine. So the video basically just said it was 2 Silent Night at Christmas, and it had some, Christmassy music of Silent Night, and it showed a temporary accommodation for children, and then it just said, this is a silent nightmare, we're asking for cots to be put into temporary accommodation. As a result of that, the government are going to release new guidance in the next couple of weeks. I've seen it. Hopefully it doesn't get tweaked again, but strongly encouraging all local authorities to make sure that there are cots provided for under 2s. There's no statutory obligation at all at the moment to even have the space for a cot. So I think it's quite an interesting example of how do you take clinical evidence to then bring housing change. So it was one to think about. The other thing that we did, if we just do the next slide, is that we wanted to tackle how do we address this locally, and so we started the crib. So the crib is based under my GP practice in the basement. It was an old basement. We managed to get it converted with a bit of funding, and now it has a counselling space, a kind of open space for workshops, and it has some basic supplies of nappies and cots and some clothes. it's not about the nappies. It's never about the nappies. The nappies is a way of building trust to work out what is going on with this family, what's happening. And particularly we found that we are able to support pregnant women. So often when women are pregnant, the domestic violence increases, they end up in TA and they're like hyper vulnerable at that point. So what that's showed is that the link between having a close link between housing and primary care and vulnerable people is really interesting and really useful. I couldn't do what we do with a GP surgery without having the support of our housing colleagues and the local authority. But equally, a lot of these families come with medical issues, whether that's mental health problems, physical health problems. They need to enter the NHS, and you have a huge amount of levers in the NHS you can pull. So actually that kind of proper co-working together has been really important. We're starting to spread the crib model now out to Greater Manchester. I have an ambition to get a crib kind of presence in all areas of GM, partly because we're seeing families moving across localities quite quickly with dispersal and rehousing and stuff. So it makes sense to have a kind of bigger footprint so you can follow them through. So just kind of to finish off, I guess I'm not sat here as an expert. You guys will know an awful lot more about a lot of this than I do, and I'm really excited to learn from you. But just coming on to the final slide, I think I would just say to people who are looking to work in this area is that be really curious about what you see. I'm really glad that I noticed. One of the things I noticed in A&E was that I saw a kid who had fallen down the stairs in a temporary accommodation, and we realised that there's no provision of stair gates and safety features. So that's become one of our other asks for temporary accommodation. But connecting that story, you know, I could have just assessed the kid with a head injury and gone as a kid with a head injury, and my clinical pathway says I do this, this and this and send them home. But actually being curious about what's going on, what's the story behind the story. One of the things I've learned from my own experience is that when you cross sector, you will speak slightly different languages and you'll have different understandings, and really respect the perspective of the person sat in front of you. Their experience as a professional is going to be different. Like, I've never been a housing officer, they've never been a doctor. We have different experiences, but like the richness is how do you work together and build those relationships. Be really clear about what you're trying to achieve. And the final thing I want to say was just keep going, because all of you who are innovating and piloting, and it can be a bit soul destroying, doesn't it? And there's always someone with a clipboard that says it won't work. That's fine. It probably will. Just ignore that and carry on. So it's lovely to be here and yeah, ask any questions you want later on. Thank you so much.
Thank you very much, Laura. There's a lot to take in there, and I can see also in the chat the number of questions which you'll all get to, and also your comment about the cake factory. So lots of interesting facts as well, and nuggets. Great. Thank you very much. So to the third presentation this morning is a pleasure to welcome Connie Jennings from the Walsall Housing Group. Connie is the Director for Strategic Stronger Communities. And in her presentation this morning, she'll be covering examples of strategic partnership between health and housing based on the evidence and data of health inequalities. She'll also reflect on the Walsall Housing Group's community champion model. And this model has led to some direct referral pathways between health and housing, and also its relationship with to children with asthma. So welcome, Connie. Over to you.
Good morning, everybody. Thank you so much for inviting me to speak to you today. I'm really disappointed you didn't mention the Connie Caterpillar cake at Marks and Spencer's, because I feel like my name's trending at the moment. Well, it's all about cake this morning, isn't it? So yes, my name's Connie Jennings. I have the real privilege of being the Director of Stronger Communities for WHG. The services in my area all strive to tackle health inequalities driven by the wider determinants of health. What's interesting about that is that housing isn't naturally per se included in the integrated healthcare model across the country, but WHG have managed to use its very sharp elbows and get themselves around the table and ensure that we're influencing decision making on behalf of people that live in our homes. So the work's important to WHG because we recognise that despite having the worst health, our customers often have the least access to services. And as the next slide will show you, unfortunately, Walsall, where the majority of our homes are located, is very poor and it's very ill. It's easy to look at words on a slide and think, yeah, I know that and I understand it. But the reality is that people's basic needs are not met. So children and adults are cold, hungry, and lack the types of access to facilities that the rest of us take for granted, even really small things like being able to send your child a birthday card, as an example. People are living slightly longer in our sort of area, but they're not living a good life. Their health life expectancy is in the mid-50s, and they're dealing with very chronic long-term conditions, some of them respiratory, such as asthma or COPD. And as you can see from the next slide, WHG are very committed to working in partnership as part of the Integrated Care Partnership. We have just over 21,000 homes in a number of local authority areas, but around 90% of our homes are located in Walsall, which gives us the ability to be an anchor institution and work at scale, which then enables us to demonstrate impact. We are members of the Walsall Together Integrated Care Partnership board, which enables us to make those strategic as well as the operational decisions which impact on our local communities. We work really closely with clinical leaders within the health sector, but what's interesting about the work that we do is the recognition from all of us as professionals that each of us need each other, and that we couldn't do this innovation and changes to the system without working together holistically and being extremely person-centred. So WHG frame this work, as you can see on the next slide, as part of our corporate plan, Successful People, Successful Places. And it was driven, one of the areas that I look after is safeguarding. And the work was driven by myself due to young Hakeem, who died very sadly due to a preventable asthma attack. People talk a lot about AWOD, but our work was driven before that. I looked into his case and was really concerned to look at whether there was any correlation between children who were dying from asthma or going into hospital on a regular basis and social housing. And surprisingly, when you overlaid the data, there was a strong correlation between poverty, ethnic minority groups, and social housing or poor private housing. And so that particular information drove a number of actions, and we launched ACE as a very practical, low-cost proof of concept in 2022. And what is important to note is that customers whose children were going into hospital with asthma were part of the design of the ACE programme. We called it ACE purposely to have a bit of strength-based language around adverse childhood experiences, because ACE is often referred to children from disadvantaged communities in a negative way, and we wanted to take that word and turn it into a positive label for children and young people who, through no fault of their own, are often at the mercy of ACE. So as you can see from the next slide, WHG's strategy, Successful People, Successful Places, we have invested in health inequalities for nearly 20 years, so it's not new work to us. It's good old-fashioned community development, strength-based work in communities. About 5 years ago, after COVID, we co-created the health and wellbeing strategy, the H Factor, with a focus on trying to ensure that our customers, were healthy, had hope for the future, and had some element of happiness in their day-to-day lives. Their lives can often be so tough, it can be very hard for them to self-actualize or motivate themselves to engage in things that would improve their lives, but they're so overcome by risk and vulnerability that it's very difficult for them to take that first steps into making a change. We launched our social prescribing programme just before lockdown in recognition of the over medication of social problems. So you'll often see people told that they've got anxiety or mental health illness, and it's actually the fact that they don't have enough money in their purse to feed their children. And our social prescribing programme really strives to provide a social intervention instead of a clinical intervention for people who are not ill. They're merely poor and not accessing ordinary services the rest of us take for granted. So the work, as you can see on the next slide, started around 2023 for ACE. The whole of WHG's programme are based on engaging with our customers. I'm really proud to say that over 60% of my team live in our homes. So the people who are struggling with the issues that all of us are trying to deal with today are actually the people who are providing the solutions. An area of disadvantage, that have lived experience of the health issue that we're trying to deal with, have been able to demonstrate resilience and coping mechanisms to deal with that particular issue. And what they do is they go into communities on an outreach basis, acting as a Pied Piper and a human bridge. I always say there's not a lack of services, there's a lack of access to services. So community champions are that human bridge that helps people into the services that they need by using coaching and motivational interviewing techniques. We also use a lot of incentives and hooks. So we try and meet people's basic needs as a starting point, and we ensure that people that are working alongside our customers are culturally competent. They look like each other, they talk like each other, they meet each other in places they go to in their day-to-day lives. We don't expect people to come to us, we go to them. And we ensure that what we do is evidence-based. So we use a theory of change model, and we use the Warwick and Edinburgh mental wellbeing scale to measure the impact that we have with people at the beginning, the middle and the end of their journey. The model that we use in ACE can be lifted and shifted to any sort of issue. That the model is the building block for the work that we do. So as you can see on the next slide, we wanted to identify children who lived in our home and had poor asthma. But what we knew was that that might be driven by environmental factors. So we ensure that when we get a referral, which we establish a pathway between our paediatric unit at our local hospital, they ask people when they come in, do you live in a WHG home? We house a fifth of the borough, poorest people in the borough, so quite often it is one of our homes. And what we do then is we send out a social prescriber and one of our asset colleagues to go and visit the home to ensure there are no environmental factors that are driving that poor asthma control. We also do an holistic assessment, which we take into account a huge range of things like fuel poverty. We look at whether a lot of our homes have their gas capped because of poverty. And obviously cold homes drive poor asthma control as well. So although the issue is asthma, it's actually an opportunity to have what we call a clever conversation, which is a coaching conversation where we ensure we collect all of the information required to ensure we do an holistic response to that customer's needs. As you can see on the next slide, in terms of that approach that we use, really important to have a practical operational working group. We work with the lead for asthma in the Black Country, so we don't do this in isolation as a housing provider, we do it very much with our health professionals. All of my frontline colleagues have been trained in asthma awareness, take a very similar approach to safeguarding. So safeguarding is everybody's business, and now we want asthma to be everybody's business in WHG. So if they see flags for asthma in a home when they go in, such as discarded inhalers, child looking very poorly in the corner out of school, our colleagues will be curious, as Laura said, and ask those questions to try and obtain information about whether that child has got a respiratory condition. The tier 1 training is basic information, advice and guidance, and it's delivered by our health professionals, and it equips housing professionals with the opportunity to ask some important questions, which then our health colleagues can use in terms of their clinical intervention. As I said, child poverty often goes hand in hand with poor asthma control. So one of the things that we do very practically is provide children with warm winter coats and winter shoes using our social value money. And we also use fuel voucher schemes to ensure that people can afford to heat their home and keep those children warm during, particularly from September up until March. It's work in progress, as the next slide shows you. We haven't done a huge amount of work in terms of numbers, but what the work has been able to show us is that there is an issue between children with asthma and damp and mould, and that housing needs to be part of the solution. Our mantra is, if we can't move the damp and mould, we move the person. We're very ambitious for ACE. We're working with the National Housing Federation and the Chartered Institute of Housing to try and look at launching a concept we call asthma-friendly homes. And all that would require housing providers to do is to train their frontline colleagues to understand the triggers and the signs of asthma, and to align their asset surveying team with any frontline services that are dealing with community investment and health inequality stuff within their local housing provider. The other thing that we've just started is we're working with a sensor provider. We're now collecting data from families where children have asthma. We're looking at carbon dioxide levels, we're looking at ventilation, we're looking at temperature levels, and we will use that data along with the soft outcomes collected from ACE to inform the next stage of this proof of concept. This programme costs less than £100,000, and I don't know how much a hospital admission for a child going into hospital is, but when you look at the socio-economic costs to the child and the wider family, missing school, which contributes to that disadvantage, parents missing work, which contributes to people being in poverty, it seems to me a really excellent intervention to change people's lives and to ensure that children have the health equity that they should have in line with other groups of children in the population. Thank you.
Thank you very much, Connie. I think there's so much for us to learn from what you've said, even just from the last slide. There's a lot to take in. So we'll hopefully have more time for the audience questions to come through as well. So thank you. So that brings us to the close of the presentations part of this morning. And we'll now open up for panel discussion, and then we'll open up for questions from the floor. So range of presentations, and they're all picking up different approaches, but there are also some similarities in all of them, which is about culture and behavior change, both as organizations and as people that you've all kind of led. I'm curious to hear from the panel what actually drives and enables and sustains this. And, at an individual level, we've seen what Laura's kind of tried to do and what she's now grown to. And as an organization, both the housing organizations have done some immense work with their residents. So I'm very interested from the panel's view on what really drives this and how do we sustain it long term. Anyone wants to go first? So
I'll go first.
Yes.
So what drives me individually is my lived experience. So I've got 50 years of experience of living or working in disadvantaged communities. I had a brother who had severe asthma, never made the link of the child between the fact that my father smoked heavily in the home, and that would obviously have driven those emergency visits to hospital. Organisationally, WHG's board have invested in this space for 20 years, so for as long as they've been in operation, in recognition that we know through the residualisation of housing that our allocations policy within the housing sector over the last 20 years has been based on providing people who are in need with a home. By default, that means that your customer base are not going to be a cross-section of society. They're going to be a group of people who are extremely vulnerable. I'd urge people to read the latest Spotlight report from the Housing Ombudsman, A Relationship of Equals, because that clearly sets out that it's not enough to say we're a general needs housing provider, because general needs doesn't mean no needs. And I do another presentation I call Our People, Your People, in recognition that the people that live in social housing are the very people that are in hospital or visiting the GP or visiting the emergency room in disproportionate numbers when compared to a cross-section of society. And that is because, unfortunately, due to the lack of social housing, it has been allocated to people that have those vulnerabilities and risk factors. So our board is very clear. It's part of business as usual. They invest and are committed to ensuring that our customers have an opportunity to improve their health.
Thank you, Connie. Sarah, David, Laura, do you have anything you want to add to?
I think Connie said that really, really well. It's difficult to follow actually, but just from my experience, you know, I have been a housing officer. That was you know, the job that I started as a housing officer, going into people's homes, seeing the conditions that people lived in. I still go out today with our estate teams and still see, in some cases, worse conditions than what I was seeing 20 odd years ago when I was a housing officer. So you know, I have a personal kind of passion and drive for housing and health to collaborate. But I think in order to get that momentum, you know, we have to, as leaders across housing and across health, build that capacity into teams to encourage and drive people to develop the collaborations and the partnerships. Giving teams the capacity to do that is really important, and that's what we've built into in Wakefield and West Yorkshire.
Thank you, Sarah.
I think all of us kind of agree, don't we, that seeing reality is really important in motivating, actually. So I always encourage people, whatever their role, to try and make sure that they do experience some frontline things. And some of the most powerful experiences we've facilitated is for, you know, very senior people in GM to come out with us for you know, an afternoon and go and visit some of our families and go and talk to them and go and see some of our patients. And I think I would encourage everyone at all levels to actually make the space to do that, clear your diary enough to do it. It's always humbling, and you always learn stuff, and it's the kind of experience that stays in your head and goes round, and then you think, oh, but we could do this. And then I think for me, I'm eternally hopeful. I think you have to be slightly hopeful to stay in this work for the long term. So there's a combination of dissatisfaction, not accepting the status quo, and hopeful that change can happen. And you have to be good at building bridges and relationships, don't you? So those soft skills, we can all write a strategy and we can all have a plan, but if you don't get it through a board and you don't get it through the finance team and you don't get it to your frontline workers to actually adopt it, it stays on a PowerPoint. And so for me, that's the kind of nub of work, really, and the joy of work is that bringing people along on this journey. So yeah, I think there's lots of ways of doing it. Just don't give up. You know, have a grit is don't give up.
Hope is beautiful. Thank you, Laura, for that. And another strand that I see consistent in all of your presentations is also the value and the importance of data. Although from our lived experiences, we often know what's needed, sometimes it needs numbers to communicate to those powers above to actually have a strategy or a program in place. So I was interested to kind of hear from you about what were some of the barriers you had to overcome in terms of securing data and also insights and sharing this to make a compelling case for what you're doing now.
I've got an example of that. So data in housing is pretty poor. A lot of organisations don't know who lives in their homes, unfortunately. So they start off, you know, as a couple, and then they have a couple of children, but there's no onus on the family to update the fact that they've now got a couple of children. So it's a massive feast to be able to know who lives in your homes. And obviously people age while they're living in your homes and their circumstances change. In the Black Country ICB, Integrated Care Board, they've invested in a platform called View It, and they've given access to all of the wider partnership of the Integrated Care Partnership. And we were able to overlay our postcode data across all of the health data. And what that was such a game changer for us in terms of health, having a strategic relationship with housing, because it demonstrated that 82% of WHG homes were in what they call a core 20 area. So a core 20 area is the 20% of the population that are most disadvantaged, you know, the worst of everything. And when they could see visually that cohort lived in our homes, that then enabled us to say to them, we're the people you need to be having the conversation with. If you want to reach your people that you call hard to reach and I call failed to reach, there's your data, and here's the people that you need to start talking to. And that was because health love data, don't they? They love a graph. But when you can combine the data with the lived experience stories and some of that anecdotal evidence, you've got a really powerful catalyst for change.
Absolutely. And also, David, you touched on in your example about some of the projects that you've been leading and the importance of data. How easy, as an organization responsible for huge numbers of housing, similar to Connie's example, have you found kind of having access to data and sharing the data?
Yeah, we were quite fortunate over the last couple of years. We embarked on a project called On Your Street. So that's where we reconnected with all of our customers, 32,000 of them, out on a door knocking exercise. So we're able to find out, as Connie was saying, there's no ownership on those tenants to actually give up who's behind those very doors. Ultimately, we get the name of the tenant, but have they got a partner, have they got children, etc., etc. So we were able to ask those questions and get data down to a granular level, not just in a regional area, but down to the street. So we're quite well fortunate in that, in terms of some of the learning and some of the outcomes that we've got from that. And then in terms of that, we've responded. So my services have then responded in terms of delivering adaptations, wellbeing support initiatives, and then ultimately, once we've embarked on that journey and completed that, in terms of, we're still going through some of the process from the summer of last year now. Once that's complete, then I suppose some of the data sets that we'll get out of it, we can then further take to the forums that, say, for example, that I'm chairing at the Housing, Health and Social Care Partnership, and have conversations with other providers to say, look, this is some of the issues that we've been faced with. Is there parallels to some of the stuff that you guys are seeing in your organisations, in the areas that you're working in, the localities, etc. So I suppose then, once you've got that, you can start to scale up. And I think, going back to your first question, it's about having the right data in terms of making sure that once they're aligned with some of the healthcare costs and the associated costs we talk about, like, say, for example, ambulance admissions, etc., and stays in hospital, it's then that when health and commissioners is pick up really, and then that's when we can start to shape and influence conversations to try and mold services at a more, at a social level really, and addressing those determinants of health on the back of that, as opposed to escalating into A&E or into a GP setting.
Laura?
It's just so data for me was a game changer in people realizing that action was needed at kind of national level. Until then, I banged on and nobody was really that bothered. So it was a really key moment. So I think it's also about what's the data you're missing. The next bit of data that we're collecting is, I've asked A&E just to ask every child that comes in, are you living in temporary accommodation? So A&E had never asked that before. So there's no national data about children having accidents or admission rates or anything. So that was one question. The receptionist can ask it. It's not a big exercise. It actually doesn't cost any money, but in 2 years' time, that will give us the first data set. So I think there's also something about what data we've got, or what data's missing, and also what's really pertinent, because we kind of swim in a fog of data, particularly in health. I assume it's the same for housing, but we are like overwhelmed with data. So you need to be really wise in what does it mean and analysing it. And also, people hide behind crap data. So it's not the panacea, is it? But it is really useful when it's used well. Sorry for my language, everyone.
Sarah?
Yeah, I've just got an example of where data was used for the hospital coordination project that Dave mentioned in his presentation. So we originally in Wakefield, they often had, during the course of winter, these particular days where lots of partners would come onto the ward to look at people who had been bed blocking for a long period of time, and everybody get their heads together to look at all the information to see how we can help to start moving these patients on. And I went along to one of my first ones that I went along to, and it was quite evident from a lot of the conversations that housing hadn't been thought of at all in that patient journey, whilst they were in hospital, until the point of, you know, actually they are medically optimised, but now they're homeless or they've got nowhere else to go. So we're trying to sort all of that out. So that's where we needed some more data in order to get the commissioners to listen to us about trying, or as a proof of concept, the hospital coordinators. So we looked at the hospital discharge data that the hospitals were inputting as to why somebody is delayed. And there was actually a code on there for housing, a housing delay or an adaptation delay. So we were able to sort of collate the percentage over the course of, I think it was 2 to 3 years, of people who were delayed due to a housing barrier. And it worked out, it was something between 7 and 10% of the patients with delayed discharges because of housing. So that was what kind of nailed our business case to trial the housing support coordinators and have that proof of concept. But unfortunately, like a lot of other things, you get somebody else who's data inputting, and we started to lose that information because somebody else came along, they were inputting the data differently. So they would put it down to, say, patient choice, for example, not wanting to move out of hospital when actually they couldn't move out because maybe the house wasn't suitable for them. And so sometimes that data quality was a little bit questionable, but we were able to get enough to be able to put that business case across. So I just wanted to share that example if it's helpful.
Thank you, Sarah. Connie, do you want to add anything to that?
Yeah, we've just had some very new data sets created by the Integrated Care Board, which show that social housing customers are by far the biggest users of emergency rooms within the Black Country. So that's my lever now to pull again to say, anecdotally, we're telling you this, now here's the data sets. One of the areas that I'm really interested in ensuring housing are at the table about are virtual wards. So there's a lot of hoo-ha about, oh, we've got people out of hospital in 4 days, you know, via a virtual ward. And I asked the question on LinkedIn very pertinently to say, do you know the housing conditions of the people you're discharging through the virtual ward pathway? Are housing involved in that conversation? And of course they're not. So I think from a social justice point of view for social housing customers, housing sector needs to wake up to these virtual wards, which are great because people do better at home as long as the home conditions are conducive to healing. But housing hasn't even been considered as part of that potential model.
I think what's interesting, you know, there's a real shift that I can see in the conversations across board, whether it's health or housing, about how fundamentally linked they are. However, as Laura was mentioning, that the guidance and everything we have dates back to a time when only those 2 questions were asked about social history and also whether you drink or take drugs. So we've moved on, but the system is quite clunky to move on. And all of these discussions now already is pointing to good practices, which are quite simple to start making those changes. And just general question, one more to all of you is, how do you see these initiatives that you're piloting in your own work and field can become systemic? How easy is this, from your experience, that this model can be something that other organizations can follow? And what is quite unique or specific that you think also to your work in the places you work?
Shall I start on that one? I think for our wellbeing coordinators, the mental health navigators and the housing support coordinators that we've mentioned today, they've all become mainstream services. So they all started as a pilot or a proof of concept, but they have all become now mainstream funded in the main by the health service. Wakefield District Housing do put an element into the mental health navigators and the wellbeing support workers as well, because you know it's a collaboration and it jointly benefits both us and the health service. So there is some investment goes in from us, but they are now mainstream. Took a number of years. I think what we had to do was constantly report back on results and impact, and as much hard data as we could. And I think over the course of maybe 2 to 3 years of them being what we were classing as a pilot, we eventually got that mainstream funding through. So you do need the resource and the capacity to put into sustaining those types of projects if you want to keep them.
Was there anything else anyone wants to add?
I think it's hard, isn't it? So, I mean, being honest, the cribs is entirely philanthropically funded, charitable funding at the moment. I'm trying to work with GM about that it should be more mainstream funded, at least in part. The focus care workers that we do, which is between primary care and in our practice and a lot of practice in Greater Manchester, is partly funded by primary care money, but there's a gap in funding, and pretty much every 9 months I have to go through this drama of how do we find the gap from the system. So it's tricky, but I think the more we do it, the more we show, the more it becomes business as usual. So focus care sounds similar to some of the mental health caseworkers that have been described, but they're kind of more based in primary care and more quite holistic. But that's been going 15 years, and over 15 years, I think we've had 7 different funding regimes. So it is hard work, isn't it? Some of the more systemic work, if you can get changes in guidance, if you can get changes in best practice, if you can get this adopted as normal, then it becomes embedded, doesn't it? I don't think the question about temporary accommodation will be taken out now it's been put in. So some changes are easier to sustain than others. But the sustainability is tricky. That's why we all need to keep being passionate and keep collaborating together. I don't think there's an easy answer, particularly with all the current pre-election gubbins going on. It's quite tricky, isn't it? So yeah.
Thank you very much. Yes, Connie?
I would say it's quite a multi-layered response. So I'd link the work that I do to health economics. So I look at savings to the health system as a starting point, which is quite easy to prove. So I've got a diabetes programme which demonstrates huge savings to the millions spent on diabetes by engaging people in self-care and independent access to things like the NHS app and stuff like that. I also think that from a housing perspective, the work that we do has a dotted line to tenancy sustainment. So from my board's point of view, we've got something like a 99% tenancy sustainment figure at the moment. People are not moving because they're sustaining their tenancy because, say, somebody's got, mental health issues, which might cause hoarding, as an example. We've now got a social prescribing team that can go in and ensure that person gets on the mental health pathway. So it's another lever for us to pull around tenancy sustainment. And the other thing is about an evidence-based approach. So as long as you can prove your proof of concept, with hard data, then you've got an argument for that investor save approach. And given that I think 15% of health outcomes are created by the hospital and the GP system, it's not rocket science to say, please invest in the health prevention and the health promotion instead of the crisis end of the system. And I think you need your board to understand what you're doing and why you're doing it, and for their backing from a housing provider. And that the ACE work, we're looking to mobilise the CIH and the NHF to get asthma-friendly homes, which is a really low-cost way to demonstrate, as housing professionals, we're interested in the conditions our customers are living in.
Thank you very much. I was going to have more questions for the panel, but there are a number of interesting questions coming through in the chat. So I'm going to now pick up those questions and I will direct to some of you if I know who's best placed to answer them. So there's a question from Alex in the chat, Alex Kearney, about what would the social landlords on the panel recommend is the best way for tenants and local organizations to start conversations with their local social landlords about the link between housing and health, and what can be done to improve health equity for their tenants? It's a long question, but hopefully got the gist of it.
I think we're all being very polite, aren't we, waiting for somebody else to answer. For me, it's about employing people in those roles so they are part of an organisation that can have that direct conversation with policymakers and people that are in charge of strategy. I think through the tenancy consumer standards, where as social landlords we've got a duty to hear what our customers have got to say, we need to provide a pathway for customers to have that space with their landlords to talk about what matters to them. And we need to work much harder at getting that resident engagement more diverse, so it's not the usual groups that come forward. And you know, a good resident engagement team will theme the work that they do with customers, and they need to find an ally in the organisation to be their champion. And there will be people in every housing organisation. There's a Connie that is passionate about this work, and they just need to find who that person is.
Just to pick up on the point about the best way to start conversations with social landlords, I'd say in my experience, you know, social landlords are generally always open to that conversation on housing and health. There are a number of ways you can do it. You could maybe just start at the grassroots level and call up your local housing manager and just start a conversation on a one-to-one. That can be really effective just to build up to those one-to-one partnerships. Or you could do it more strategic level and look at the health and wellbeing board and try and get something on the agenda there to flag the importance of the local area working in partnership between housing and health.
Great, thank you both. There's another question from Liz in the audience about how are organizations funding the work demonstrated by speakers? For example, the wellbeing champions, navigators, etc. So how is the funding? How are you accessing it?
I'll take this. I put that. I think I responded to the person in question in the chat function. But for us, we commit to the pilot first, and then we saw the proof of concept and the value that it brought to that tenancy sustainment element that we were looking for from an organisational perspective that complemented our vision. So we made the choice to bring that mainstream, and we fund that from an organisational perspective. Then obviously, that, like I said in the presentation, that piece of work were evaluated and it highlighted the gaps, and then that's when you get an impartial evidence set to present to commissioners at the time about looking to scale up and address that gap in service. So for us, we now fund the mental health clinicians 50-50, which was the CCG at the time, but now the ICB. So like I said, so for us, we get in that tenancy sustainment, and the tenants are learning to self-manage the symptoms. But for health, it's ultimately stopping people going through crisis and GP services. And I think as Connie has alluded to, really, it comes down to those cost-benefit analyses and just making sure, and we embed that well in terms of our social investment calculations. And it's quite evident to see some of the social dividend that we get from our organisation for investing in those services. Just amazing outcomes, really. So it is not just the right thing to do, but everyone seems to get a piece of the pie, and it is a bit of a win-win for all concerned, really.
WHG invest a minimum of £500,000 every year into this work, looking at profit with a purpose approach. So obviously we build some homes for shared ownership, and there's some profit from that, and so some of those profits are reinvested into our development programme, but also this work. We obviously have to work very hard to secure grants. I hear Laura's pain. It's so frustrating to go through all these hoops to get money when you know the benefits that will happen. The social value outcomes reports that we do are a really good lever. So if you improve somebody's mental health using the Hacked UK Social Value Bank, that's £36,000 social value created just for that one person. But I think the biggest thing that we've done at WHG over the last 12 months is to ensure that our clinical, our health colleagues understand that the people that are taking and drawing down on health services live in our homes, and by investing in the work that we're doing, they will ultimately save money within the system. And when resources are so stretched and, you know, services are retreating, such as the police, you know, right person, right care, it's important that we as a system that's wrapped around disadvantaged people work together to get the best solution for that individual and that wider community. And we can only do that by sharing and stretching resources.
Great. Thank you, Connie. I think, Laura, did you have anything you wanted to say from your experience from setting up the service in the estate?
So I know primary care money best, really. So there's something called R's, which is R's roles in primary care, which can be useful if you work with your local primary care organisation. Primary care is currently structured in something called primary care networks, which cover about 50,000 people. So it can be a useful way of working together with the NHS. So some of our stuff has been funded through R's roles, which isn't long-term sustainable funding because the commitment's only till another year. But I think it's become such a big change in primary care, it will continue whether they rebrand it a different name. So that's one thing to look at. The PCNs are also led by a PCN clinical director, which is normally a GP, but they particularly have a remit at the moment for looking at health inequalities, and they have a big scheme of what they call population health management, which is effectively what we're talking about here. So those are kind of a few buzzwords if you wanted to link with primary care. I think I would encourage social landlords, well, to also go and talk to primary care as well, because there's huge overlap, as you guys have, or we've already shown, but there's also potential money from the NHS that way. So yeah, it's worth about being curious. Particularly, I shouldn't say this on a webinar, should I? But particularly this time of year, the NHS has suddenly realised, well, it's underspent, and sometimes they'll slosh money out for a pilot this time of year. So there's no promises because I don't hold the purse strings, but it's quite a good time of year to go and be innovative with the NHS about tackling social inequality.
Laura, do you mind if I just ask, because this sort of recommendation has come up a lot through the network, but also through work that Future of London has done previously on the link between the built environment of health, of, you know, speak to the NHS or speak to primary care. Are there particular kind of forums for doing that? Is, you know, who would you say that needs to be arranged with, and how specifically?
Yeah, I mean, the NHS is an utter nebulous conglomerate, so it's tricky to navigate. So in a local authority, there'll be a public health director. They are now based in local authority. They have quite a lot of influence into the NHS through the ICB. They're always good to have a talk to. Things like childhood asthma is pretty on. If you're in a socially deprived area, childhood asthma is quite high on their list. It flashes red on all their spreadsheets. It's really good to go and approach them if you want to copy any of this. I will be copying some of this, I've heard this morning. So that's a good one. The primary care directors for the primary care networks are like a hodgepodge bunch. Some of them are brilliant and some of them are not brilliant, but it's always worth at least scouting out who your primary care network is. In some areas of the country, primary care is then structured into kind of the primary care directors will meet together and they'll have a spokesperson. Again, it's a bit like Connie. Connie's obviously ended up in her role because she's brilliantly brilliant, but also she's passionate. We're starting to see the next generation of doctors coming through who are more socially justice aware and are getting to more senior roles. So it's worth talking to them. And then every locality in every ICB will have a director of primary care. They're often really bothered about things. Measles at the moment is massive for us. They're bothered about admission rates. Within the NHS, there is normally somebody in secondary care called the transformation director. They're worried about bed blockers. So if you can see them, they'll often have routes and pathways. So it's about trying to work out who is the person who's got the passion who will help you. And they may or may not have the right job title, but there are loads of them in the NHS. But they are a bit hidden. Is that helpful?
Looking at the questions, I think there has been also other questions. I've picked that up. Is You mentioned, Laura, about the 5 asks to the TA, and one of them was the CODS. So what are the 5 asks?
So one of them is about cots for every child under 2. One of them is a commitment to safety features in TA, so stair gates, plug sockets, radiator covers, please. I just saw a kid a couple of weeks ago whose hand was completely burnt by a radiator that was the mum couldn't turn down. The other one is about, we're trying to push for people to be really aware when they're placing families in temporary accommodation that they don't place them in the same hostels as single homeless men. They're both hyper vulnerable. They're both very needy. They're not groups that mix well. And we've had lots of evidence about propositioning and grooming and all sorts of stuff. They're just not good to mix. So we'd like some statutory guidance on that. I'm pushing for the same access to education rights for children in temporary accommodation as looked after children, because the local authority understand that, as we find a lot of children struggle to get into school because the schools are oversubscribed. And the final one we're saying is that families in temporary accommodation need proper wraparound care. So we would like the crib model expanded, not for us to provide it, but these families do need someone to help them navigate re-registering with a GP, going to school, getting a buggy, all the practical stuff. And we're finding that our experience is that housing officers, either social landlords or local authority housing officers, just don't have the capacity or time to do that. And we've done a really interesting pilot where we've put a psychologist in to talk to families who are going through TA, and it's just been ground changing. So it's not about replacing the normal NHS services, but it's saying, how do we help you make sense of now, and how do you make safe decisions for now? Because often people, their whole worlds are turned upside down, and you find that they make decisions that maybe aren't the ones they'd normally make. So that's been a really interesting pilot. So we'd like to see that kind of intentionality added into it. So yeah, thank you.
This is such an important topic because all across the whole of the country, local authorities are struggling with the levels of TAs going up. Often it can be seen as just the accommodation is the kind of the most fundamental thing. We need to get it. And it's very easy to kind of miss out on some of these kind of essential elements, which you'll see at the other side with the hospital admission and the longer term impact on children. So I think it's something for us all to take back and see in our work we do, to what extent we can incorporate these, even if there are no guidance, but, specifically when you're looking at TA, given the volume and the numbers of children in TAs that I think the record showed.
The other thing that we haven't written up yet is, but I'll just put it into your brains, is long-term contraception. So we're finding that a lot of these women are pregnant or have got children and they don't want another baby at the moment. And long-term contraception is really helpful creating the space for women, and they need advocacy to get into those services, because then those services aren't designed for those people really, which is another thing. But if you can get housing officers or anybody to ask about long-term contraception and advocate for it, it's completely ground changing for women who are in these difficult situations. So that's the one just to throw into your headspaces.
Thank you, Laura. I'm conscious we have 2 hands up on the screen, which is great. So Catherine, do you want to go first?
Thank you, Shri. I've noticed there are a couple of questions in the chat about the private rented sector, and that sector is not represented directly on the panel, but all of you through your day-to-day work and strategic roles are probably encountering in the good, the bad and the ugly in the private rented sector, which of course, picking up on the huge number of people in temporary accommodation, we know there's a lack of social housing per se, let alone good quality social housing. So private rented sector is hugely important. So I was wondering if you had any experience or reflections on engaging colleagues in the PRS or working with PRS on these issues in a positive way.
Are you asking the panel, Catherine? Yeah. In Walsall, there's a strategic group that looks at all accommodation cross tenure to try and work collectively. And what WHG does is workplace based. So if we've got funding to work in a geographical area that's disadvantaged, we will work holistically in that area. So we won't say we can work with you, but we can't work with you. In 30 years of working in housing in disadvantaged communities, I don't think I've ever said to somebody, I can't work with you because you live in private housing. We recognise that people in private housing may have fallen out of social housing for whatever reason and are therefore more vulnerable. And they are more vulnerable because they're not getting that wraparound support that social landlords routinely provide. So I think place-based is the approach to take when working in disadvantaged communities and stretching that asset and resource so that it benefits people within that geography rather than on a tenure basis.
Yeah, that's same for us in Wakefield. So as Sarah said, I chair the Health Housing Social Care Partnership, and as part of that, the local authority's housing plan sits with that. A lot of key actions, but also a lot of other registered providers are there, but it helps to shape and influence the local authority's strategic housing. So irrespective of tenure, I suppose there is the voice advocate around that table, and ultimately some of the services that we do commission or some of the projects and pilots that we do embark upon is inclusive of people cross tenure. So, for example, in the housing coordination function, you're a patient, it doesn't matter where you live or what background you come from, you will have housing coordination services. Same with our Warm Homes initiative, irrespective of the tenure, wherever you live, if you've got a damp mold condensation issue, we will be able to reach out to you and provide that wraparound support. So it is getting more and more inclusive into the commissions and work that we're in the space that we're getting into. So yeah.
Great. Thank you, David. There's a question in the chat, but I'm conscious Suzanne has her hand up. Susan?
Yes, I hope you can follow me. I'm autistic. I work with my counsellor as a disabled co-producer. I would like to know from any of the panel, what support do you put in place for autistic households? Because the NHS principles, as they've been published, it goes learning disability and or autism. And that sometimes leaves autistic families, because we don't fit into certain criteria, that it isn't holistic as yet. We have people moving into new builds where there is no infrastructure to support them. There's no GP services. They're living alongside people who can afford private treatments. So I'm interested in what Laura would say about setting up a GP practice in vast new build developments. How do you argue the case if you don't have the data and evidence of how many families that would come into core 20 principles living there? And then the Wakefield thing, you said about sensors in the home. We have lots of people who are autistic living in disrepair homes, damp, mold, not safe, the wrong floors, no lifts, all that kind of stuff. What other forms of assistive technology any of you use to measure health within homes? It's quite common. Sheltered housing have all sorts of sensors to measure falls and that sort of stuff. But we have people who are autistic who've got eating disorders, OCD, people with asthma. I'm interested in knowing more details, David, on the sensors that you said for Aware that are proactive. If slides are given, will there be any extra information given for the companies that you partner with? Because I'm working a housing working stream where I sit on access to health boards. I'm an Imperial Community partner, but I'm also a housing activist. How do I harness myself to do some of the things Laura's suggesting to do to sort of go and chase some funding?
Thank you, Suzanne, it's quite a wide scope of questions. So
yes,
the panel may or may not be able, but welcome any thoughts on that. Thank you.
It's really lovely to have your contribution. I think definitely in the NHS, we are not great at working with our neurodivergent community very well. From the work we've done on temporary accommodation, the families that struggle the most probably have the most needs and the least looked after are families where the children are neurodivergent or the adults are neurodivergent, and then also the families where there is a disability, particularly for children if they're waiting for diagnosis. The waiting lists at the moment are really long, and that is particularly difficult for children in temporary accommodation. So it's something that I'm really aware of. In terms of setting up new GP practice, there isn't a national policy on where we put new GP practices, which is I think, fairly shocking. I would like to see planning laws change so that you know, we look at civil infrastructure when we're building new housing, new estates, and particularly if our kind of density of population increases as well. We're not very good at recognising that for public sector services. So I think you've got a really valid point. This isn't really about core 20%, because our neurodivergent community crosses lots of demographic barriers, which is brilliant. It's actually about us working with the community to work at how do we respond better and to learn more. I think it's something personally I've committed to with the organisations I lead. I've got 2 neurodivergent children, which are beautiful and challenging and everything in that, and possibly a neurodivergent husband, but he might not realise it, or maybe that's just him, I don't know. But it's interesting, it's a challenge, isn't it? And I think we need to be listening and co-producing and be co-curious together. And I think the technology side is really fascinating. And again, there's no one answer, is there? For some people, technology is the best thing ever. For other people, it's like another annoyance and another hindrance. So we've got to pick the technology for the situation and the person. And technology advancing all the time. I am interested in what happens. I'm also really curious. Someone said about the virtual wards, like we can't solve human problems totally with technology. And so we just need to keep that in mind when we look at all this in the round. But keep advocating and keep championing your community. Sounds like you're doing a great job. Fascinating conversation.
Yeah, absolutely. Oh, do you want to go in, Sarah, there?
It's fine.
I was just going to say, I think in terms of some of the learning, Suzanne, that we'll get from the housing coordination function at regional level with regards to learning disabilities and autism, because we all do things differently, Wakefield Place compared to what's happening in Calderdales, Kirtlees, so Bradford, etc., across our West Yorkshire footprint. So we'll get a lot of learning from that housing coordination function that'll help to shape services further. In terms of some of the things that you talked about in terms of the technology side, the switch is just a product to deliver data for housing providers to get that insight into proactively managing homes. It was just for an example for that. So whether we choose to partner with them or AwareTag or whichever provider, it's just about having that information in real time so we can respond in a proactive way, not just for people with learning disability or autism, but just for all of our customers who are potentially living in damp, mold and condensation. And then building on what Laura said there about the technology side, we've done a lot of great pilots in Wakefield with trial the ARM technology. So that's advanced risk modelling for early detection that can preempt a fall up to 3 weeks. That looks at hydration levels, saturation levels, really, really powerful pieces of kit, really discreet little sensors that you wear around your wrist. So yeah, there is a lot of things that are out there that will help keep people safe and well and independent, and ultimately keeping them in their own homes for longer. And from a landlord perspective, that is the aim for us in terms of providing that tenancy sustainment. As Connie's figures, 99%, that's amazing in terms of keeping people in their home for long, because there's a cost associated with that, but not just in terms of the financial side, it's the ethical side. It's just sometimes it's just the right thing to do, and making sure that people have the best opportunity. So whenever we can invest in technology, then we have a commitment from our organisation into doing that. Sarah, do you want to add anything onto that from a WDH or West Yorkshire perspective?
Yeah, I mean, I was just going to say, Suzanne, thank you for highlighting it. I think you have highlighted gaps and the importance that further work is needed for people with autism. In West Yorkshire, we were particularly conscious that we didn't really have an understanding of what the demand was for housing for people with learning disabilities and autism. So we have just completed a market needs assessment focusing on that group. So looking at specifically designed housing, what is needed. And the housing providers across West Yorkshire are now looking at that. We also recognise that within our housing organisations, we were not particularly skilled in dealing with people with autism. So the West Yorkshire Housing Partnership, again, commissioned some training, and we're looking at trying to get autism champions across our West Yorkshire housing providers as well. It's not yet in place, but it is something that we are looking at on our plans.
Sarah, can I suggest you look at the Oliver McGowan training?
Yes, Yes,
Yeah.
actually, I believe that's what it was actually, Suzanne. So thank you, but
Yeah.
I'll double
That's
check
the
that.
gold star thing that
Brilliant.
we're all endorsing. Because I also work with Autistica, which is the NIHR's funded research thing for the whole of the UK, and that's the one that we support.
Fantastic. Thank you. I'll check that, but thank you for that.
Right. Thank you all. I'm really sorry. I'm conscious there are more questions in the chat, but because I'm conscious of time and we want to finish it on time for everyone who's given the time this morning. So what I would suggest is that we connect you to speakers that you're aiming those questions to later on outside this conversation, if that's okay. Great. Thank you. So I just want to kind of briefly bring Nicola Kay into this conversation before we kind of wrap up the session. So for her reflections from a London Integrated Care Board perspective, and also how the discussions and the learnings might spread beyond the places where they've been piloted. So welcome, Nicola. Nicola is the Director of Partnerships, Population Health and Reducing Inequalities for North West London Integrated Care Board. Over to you, Nicola. Any reflections and thoughts from the sessions and the discussions this morning?
Hi, morning everybody. Hopefully you can hear me okay. When I was asked to give my reflections on this topic, I was like, yes, brilliant. I'm really happy to come along and do that. But as the morning's gone on, I've got more and more nervous about how to do it, because I think the speakers that we've had are so knowledgeable and have spoken so well about this issue that I feel like, can I really do that justice? So I will do my best, but I apologize in advance that I probably won't be able to do it full justice. So as mentioned, so my role is around basically reducing inequalities, embedding a population health management approach in Northwest London. So I lead that health equity program and really thinking about where are the kind of disparities in our different communities. And when we were talking earlier about some of those people in the NHS who might be interested in this sort of space, I definitely think that thinking about people with inequalities title and inequalities in their job title is a good place to look. As part of my scope, I look at the wider determinants of health. So as well as thinking about inequalities within healthcare and sort of inequalities in access, experience and outcomes in terms of services, I do think about those wider determinants. I think about how can we support an environment to help people live healthily, whether that's about what the people eat and exercise and green spaces, or about housing. So that's a really important part of my role, and I am really passionate about this agenda, but I'm not an expert in housing. That's not my kind of my background, but obviously as it is such a important wider determinant of health, it's definitely very much part of the agenda that I want to push forward in my ICS. I think that the role of the ICS is still emerging in terms of housing. Obviously, this is a really complex landscape. There's a lot of stakeholders, and I think in Northwest London and part of the in the ICB, sitting as part of the ICS, thinking about what is our role as an ICB, what can we do here, because so in Northwest London we've done a lot of work with our communities to really kind of understand some of the challenges they face. We go out and talk to them a lot about coming in, sort of what matters to them. Sometimes we want to talk to them about specific healthcare issues, but one of the big things that keeps coming back again and again is we don't really want to talk to you about healthcare. We want to sort out other issues around wider determinants, and particularly housing keeps coming up again and again as a thing people really want to talk to us about. So in that work with communities, we really see that issue being raised over and over again, and we're really building our understanding of the challenges people are facing. And I know it's been mentioned in this conversation, and Laura mentioned it, I think, around really making that time to get out there and listening to what people are saying. So we really try and do that in Northwest London and understand those issues. We're very lucky in Northwest London in terms of our data. So we've also been looking at kind of what that quantitative data is telling us about people who live in Northwest London. What are their health issues? How does that connect to their accommodation? So we do have really good linked data sets. We have a better understanding. We're building a better and better understanding of the housing status of our residents. So using the unique property reference number, for example, trying to link that data together and really understand where some of those issues are. So we are really lucky, and we are trying to make the most of that data and information to really think about what are some of the issues we might want to address. We've also, as an ICB, invested in a project on healthy housing. So that's a pilot project to look at supporting people in the private rented sector, supporting tenants and landlords with practical information and guidance on creating and maintaining healthy homes free from dangerous damp and mold. So particularly focusing on that kind of damp and mold issues in the private rented sector, really think about kind of what's some good practice there, training up community groups, making the most of resources that are available. And I'm very happy to share information on that pilot if people would be interested in finding out more. And then one other thing that we've been doing in North West London is trying to build on some of the work that's already happening. So it was mentioned earlier again about discharge. That's one of those areas where we have a lot of work happening. We can be really reactive in the NHS. So we have a bit of a history of sort of trying to solve today's problems and sort of really be quite reactive about them. And so what we do have work in the kind of housing and discharge sort of space that's happening. So I've tried to kind of piggyback on that almost and try and then turn that into, well, we've already got a conversation happening about housing, but how do we turn it into a more proactive conversation about housing? How do we think about getting upstream more? So instead of just about thinking about housing when people are being discharged, how do we stop people going into hospital in the first place and think about keeping them healthy in their homes? So I've used that as a bit of a vehicle to try and get the wider health sector, so people around me who are more focused on some of those acute and reactive things, to start thinking about kind of those upstream proactive things. So it kind of helps connect to their agenda and they can see some of the benefits. So there's a few things we've been doing. In terms of sort of some of my wider reflections in terms of what good looks like, I've been thinking about kind of what are our levers as an ICB, so as the NHS. And I think it was Laura who mentioned that the NHS does have a lot of levers, but I think we don't always know what they are and we don't always know how to pull them correctly. And so that's something we're definitely actively thinking about, is sort of how should we use these levers? So I think the first thing I'd say is one thing that I try to do and I think we could do better at is around the spreading of good practice. And that's why today is such an important event. But even within our ICS, within our geography, so we have 8 local authorities within North West London, so it's quite a big one. We've got quite a lot of different things happening and different housing directors, and that does mean that there's good innovation. There are some really good things happening. So what I try to do is really make sure, even within the ICS, we're really sharing some good practice. We've had sort of one of our places, our local authority areas, for example, has done some really great stuff around damp and mold. So we are trying to spread that across the ICS. So I'm really trying to kind of get that culture of away from the kind of not invented here implication to really be completely the opposite of that, and as much as possible embrace what's happening in one place and can we spread it. But also looking outside the system, thinking about what other parts of the country are doing, and hence why today is so important to me, and to be here and to kind of listen and understand what is happening. So thinking about some of the good practices mentioned around sort of the smart technology, for example, that David was talking about. I don't think we're using that as much as we should. That's definitely something that I'll be taking away, and loads of other examples that people have mentioned that we can bring in and share. So I really try and create that culture of bringing in as much as possible that good practice, not being kind of parochial about things. How do we kind of just grab things and bring them in and make them happen here? So really trying to kind of listen and keep eyes and ears open to those. So the more we can share these sorts of things, the better. The second thing I was sort of thinking about in terms of our levers is around that collaboration and that kind of facilitation of kind of bringing people together. So we do need to work together to make things happen. And I think that was been mentioned around, often we can speak different languages in this sort of space. There's quite a lot of players. There's obviously, I come from the NHS side and we've got a certain language. Local authority is such an important player, of course, with their housing role. Public health has been mentioned as well as obviously all the housing providers, and then loads of others players as well. So how do we kind of come together and actually have that conversation? How do we really kind of start that and just start that happening? And sort of keep talking to find that kind of overlapping interest between health and housing, as well as listening to the communities and having that curiosity. So I think it was Connie that mentioned the word curiosity. How do we kind of build that into the conversation? So we're bringing in what's happening from our communities. What are they actually saying? Not what we think they're saying, but what are they actually saying? And joining up the kind of different players and trying to kind of really identify the areas where we can work together. And we're trying to do a lot of work in North West London around sharing the data. So kind of sharing data about who is at risk from health exacerbations. We can share some of that from the NHS side, and that helps target intervention. So that's what we're trying to do, is come together and kind of share that information, identify how we can work together more. And then the third area, I think, in terms of kind of what good looks like, is around prioritising a few areas to make a difference. ICBs are under a lot of pressure at the moment with the budget reductions that are happening, and we do need to make sure we're focusing on a few key priorities. I think there's a bit of a risk that then this work gets really squeezed because we tend to then focus more on our core business rather than kind of think about the wider determinants of health. And I see that as my role, but part of my role is really making sure we do think about this, because we're not going to make a difference to health outcomes if we only look at that reactive downstream care. So how do we keep thinking about this? We need to make sure we prioritize. We don't try and do everything. What are some key things we can do? We can make some progress, and then people can have confidence that this does make a difference, and then we can build from there. So we're sort of, for example, in North West London, thinking about damp and mold as an area to start, and really focusing down on that core 20, so that most deprived population, and really kind of making a difference for them, and then building on that. And then the final thing I would say is really kind of making sure we understand that impact they were having and really tracking that. So I know that's come up before in the conversation. I know we've sort of mentioned around the health economic side, you know, the difference that it made to the conversation that Laura was having when she had some of that data, and sort of really kind of understanding those the benefits that are being delivered through all the work that's been going on. And it's sort of how do we kind of bring that information into that kind of senior level, those senior level conversations, and really kind of get that buy-in and get that momentum from senior leaders. And so what I try to think about is like, how are we telling that story in a way that really resonates for people? So where are those sort of different senior leaders coming from, and can we talk in a way that really resonates with them and in their language, telling that story that works? And that includes the stories from our population as well. So it's not just about the data, but also those stories and sort of what it makes a difference and bringing it to life for people. So yeah, so making sure that that kind of that data and that impact is really demonstrated, because it does have such a big impact, this sort of work, but we don't always appreciate it, and we don't always talk about it in a way that really works for people, I don't think. And I would say also don't start with and also try and avoid talking about the costs, starting with the costs and the funding sources and things like that, because we can really get caught up in funding sources and things forever. But actually, how are we starting with? What are we trying to aim for? What's it going to be the impact? And get that kind of more inspiration behind it. And that's why today has been so great, because it's been so inspirational about what people have done and delivered. And I think that really gets people on board, rather than sort of thinking about where's actually the money coming from, which can sometimes turn people off. And then hopefully, kind of, if we talk about it in the right way, we really can keep that momentum and buy-in. I think that was all I was going to say. I hope that's helpful in terms of some reflections. I'd be really happy to have a conversation with anyone if I can be of any assistance with this work. If people think there's more we can be doing in our ICB, or I can, you know, we can spread best practice better. Very happy to kind of share more about what we're doing or anything. But it's been absolutely wonderful to be here and to listen to such great speakers. And as I said, I knew I wouldn't have done it justice, but hopefully that's good enough and helpful for everyone.
Thank you, Nicola. Really, really helpful. And I think, as you say, we can pick this up separately. And for those who may have questions for you, we'll connect them up. Thank you. So I just want to kind of thank everyone, and I'm conscious of time. So just to kind of briefly summarize our session from this morning, I think the stories that the speakers have shared all kind of shows not just what the organization, but also the lived experience and their personal journeys, and how much that has motivated the work and how they have led the work of the organizations that they are part of. And this goes to some of the points that Nicola mentioned about not waiting for the big legislation or the big funding, but actually starting the work because they understand and care about their residents. And we've seen the work that was presented this morning, some really good examples of what that looks like. And it's often not the big budget stuff, but it's something that emerges from knowing your population, knowing your residents really well. Secondly is also the emphasis, and I think the points picked up by the speakers about really important to understand the frontline services and what living condition looks like for the people, and how important having a workforce that really understands some of those challenges has been kind of really helpful to kind of reinforce that again in this session today. Thirdly, about data and the importance of data, but also understanding the data that is really informative and helpful to make a case, and not just inundated with data for the sake of data. And even the discussion this morning was really helpful to say what questions and what information will help make that shift and the change, and how we can expand that further in the works that we do, whether it's as a local authority, a housing provider, or just broadly health industries as a whole. And Connie's point about it's not the lack of services, it's a lack of access is a very, very important point, because there's so much out there, either in terms of offer for services, but it's the importance of knowing how we access it, particularly in a very diverse places and in big cities. And with a lot of new people coming into the cities, they may not often be aware, but they may be the ones who are most in need of those services. And how we make those access to those services as easy as possible so they're best put to use. And I also kind of was very interested in what Laura had to say about the 5 characteristics, which is like, you know, what is important. And to me, as a built environment professional working in planning and regeneration, this is also fundamental for us as professionals, and about being curious about the world we live in, having perspective beyond our fields that we work, and being able to understand each other, forming relationships that helps us to come together to address common challenges, and having clarity of vision and being clear about asking the right questions, because as someone said, you know, technology can be an answer if you know what it is for, and being able to be clear about that. And then finally, to keep going. And I really want to kind of end in summary with, again, what Laura mentioned is being eternally hopeful is a really good place to kind of summarize this session. Is that's the one thing that keeps us all going, and all the participants who are still here with us. On that note, I want to kind of say thank you to everyone, and thank you to the speakers.